Welcome everyone to tonight's presentation. This is our webinar for the Operative Standards for Cancer Surgery, a resource for resident and fellow surgical education. We're really excited for this. It's been a long time coming. We're very enthusiastic about discussing the educational benefits of the Operative Standards, and I hope everybody enjoys it. Next slide. So I wanted to briefly review the webinar logistics for tonight. All participants are going to be muted during our webinar. If you have any questions regarding content, please leave them in the chat box. It is going to be on the right side of your panel. And we will get to these in our dedicated question and answer session at the end. And so I will be keeping track of these and distributing questions throughout that portion of the proceedings. The questions will be answered as time permits, and we will send out a file later on for other ones that we can't get to. And then please complete the post-webinar evaluation you'll receive in an email so we can get some feedback and improve our future webinars. Next slide. So briefly, I'm your moderator for tonight. My name is Anthony Villano. I'm a surgical oncologist at Fox Chase Cancer Center, and I'm a member of the Education Committee for the Cancer Surgery Standards Program, or CSSP for short. Next slide. I'd really like to introduce the rest of today's speakers and panelists and thank them for sharing their expertise with us. First, we have Dr. Kelly Hunt. She's the chair of Department of Breast Surgical Oncology and a professor of surgery at the University of Texas MD Anderson Cancer Center, Houston, Texas. She's also the president of the Society of Surgical Oncology and will be sharing her expertise on the Operative Standards for Cancer Surgery as an editor. Dr. Russell Berman joins us from the General Surgery Residency Program Director and Vice Chair for Education and a Professor for Surgery at NYU Grossman School of Medicine, New York. He's also Vice President of the Society of Surgical Oncology and will be sharing his expert perspective as a Surgery Residency Program Director and educator. And Dr. Amanda Kong is a Professor of Surgery at the Medical College of Wisconsin. She's also Chair of the SSO Training Committee and will be sharing her expert perspective regarding CGSO fellowship training. Next slide. We're also fortunate to have the perspectives of trainees on our panel tonight, and so I want to introduce them as well. We have Dr. Michelle Horowitz, who is a fourth-year general surgery resident at Advent Health, Orlando, Florida. We have Jack Sample, who is a third-year general surgery resident at Mayo Clinic, Rochester. And Dr. Sarah Rudisill, who is a general surgery resident at Massachusetts General Hospital. Without further ado, we'll start our programming with Dr. Sample. Next slide.
Thank you, Dr. Villano, for the introduction and being tonight's moderator. So the aim of the webinar tonight is to spread awareness to surgical trainees about the operative standards for cancer surgery and highlight how these comprehensive technical guidelines can be used as a resource for surgical training. And the objectives for tonight are to introduce a brief history of the operative standards and what they are, and then illustrate how operative standards can improve trainee development in patient care. And then lastly, with the help of our panelists, discuss best practices for incorporating the operative standards into clinical practice and surgical education. Next slide. So as a brief history, recognizing the gap that existed in the standardization of surgical oncology guidelines, the operative standards for cancer surgery manuals were developed and published by the American College of Surgeons Cancer Research Programs. Prior to this, many of the clinical practice guidelines in cancer care focused on the medical aspects and indications for surgery, often overlooking the key technical elements that made up a quality cancer operation. In the first 3 volumes of the Operative Standards for Cancer Surgery, they cover 15 distinct disease sites and are a comprehensive collection of evidence-based best practices for performing a cancer operation, highlighting the technical elements which have been associated with improved oncologic outcomes. And to facilitate the implementation of these standards into clinical practice, the Commission on Cancers recently adopted 6 disease-specific operative standards as a requirement for COC accreditation moving forward. Next slide, please. In addition to improving oncologic outcomes, the implementation of operative standards has also been shown to reduce costs and improve other aspects of patient care and patient outcomes as shown here. Next slide, please. Within the operative standards manuals, a wide breadth of surgical oncology topics that are commonly encountered throughout surgical training are covered. For these topics, these manuals highlight the critical elements for each operation, which are the specific technical steps perceived to have an impact on long-term oncologic outcomes. Take, for example, breast cancer, as shown here. Several commonly performed breast cancer-related operations and their critical elements are covered within the Volume 1 of the Operative Standards for Cancer Surgery. Next slide. Another benefit of the Operative Standards manuals is that they serve as an easy-to-access consolidation of commonly tested topics as they relate to complex cancer care. Again, using breast cancer as an example, covering sentinel lymph node biopsy, a detailed procedure-specific recommendation is provided within the manuals, accompanied by the type of supporting data, the recommendation strength, and the rationale for this recommendation. So for trainees, we hope that these manuals can be used as a readily available resource to access things like important landmark studies and how they pertain to cancer care. Next slide. So it's kind of an outline for the remainder of the webinar tonight. Our goal is to make trainees aware of these resources in hopes that they can be utilized to their fullest potential throughout surgical training. The Operative Standards for Cancer Surgery manuals can be used to provide a framework when approaching cancer surgeries, provide a rationale for intraoperative decision-making, and improve technical skills. Furthermore, we hope that trainees can utilize the Operative Standards for Cancer Surgery manuals as a resource when preparing for the ABSLITE and board examinations, or when carrying out innovative cancer-related research projects. Next slide. We envision that for surgical trainees, learning how to approach a complex cancer surgery, that these standards may be a framework for approaching a surgical framework and allow trainees to learn high-quality cancer care while simultaneously creating a mental checklist of sorts for the critical elements that make up each operation. Next slide. For example, when preparing for a partial colectomy for colon cancer, surgical trainees can reference the Operative Standards for Cancer Surgery, Volume 1. Within this manual, trainees can find the key critical technical steps for performing this operation, such as how to properly mobilize the bowel, performing high vascular ligation, and en-bloc lymphadenectomy. Next slide. The summarization of these key technical elements may not only help trainees to create a framework for approaching these cancer operations, but also to help better conceptualize why certain technical steps are made, such as performing the extent of colon resection in respect to the arterial supply, and how this relates to oncologic outcomes. Next slide. Additionally, relevant intraoperative images can also be found in these textbooks to further help conceptualize the framework to approaching cancer operations, such as shown here, continuing with the example of colorectal cancer, high ligation of the inferior mesenteric pedicle during a sigmoidectomy for colon cancer. Next slide.
Good evening, everyone. In addition to being a resource for learning the key technical aspects of certain cancer operations, trainees may also find the Operative Standards Manual insightful when navigating the operating room and help to better understand why decisions are made pertaining to cancer care and how to anticipate them. Next slide. Many of us likely know how to select the radial margin during a wide local excision for cutaneous melanoma, but how exactly were these margins determined? The Operative Standards for Cancer Surgery Volume 2, for example, outlines the critical technical elements for performing a wide local excision for cutaneous melanoma, and importantly, discusses the evidence behind why we select width based on Breslow thickness by providing supporting evidence and data from large systematic studies and expert consensus. Next slide. The Operative Standards textbooks may also serve as a surgical atlas of sorts, helping to improve surgical skills and knowledge. Next slide. In addition to providing trainees with a framework for approaching cancer operations and the rationale supporting the critical steps, the Operative Standards manuals also provide in-depth technical information that may help to develop surgical skills. For example, in Volume 2, trainees can find a great level of technical detail regarding the operative steps when performing the mesorectal plane for rectal cancer. Next slide. Step-by-step operative details of the TME are expanded on, such as technical insights when developing the posterior plane during a total mesorectal excision, as well as key anatomic landmarks to consider. The consolidation of this relevant technical information may allow trainees to better utilize their operative experiences due to a better understanding of these procedures beforehand in prep. Next slide. As we have shown, sorry.
No worries. Thank you, Dr. Horwitz. So as we've shown, the Operative Standards manuals are a concise and comprehensive collection of the most up-to-date best practices for commonly encountered cancer operations. And for busy surgical trainees, these manuals may be a useful resource when preparing for examinations. Next slide. As shown here, the second volume of Operative Standards for Cancer Surgery covers surgical topics commonly encountered on ABSITE and board exams, such as thyroid, gastric, rectal, esophageal, and skin cancers. So if you're having difficulty remembering the pathway of the recurrent laryngeal nerve in relation to the surrounding anatomy, or perhaps the anatomic boundaries that delineate the lymph node levels of the neck, all of this information and more can be found within these manuals. Next slide. And finally, the Operative Standards manuals may open the door for numerous new research opportunities in the field of cancer surgery by helping to identify key questions for which there is a knowledge gap and an opportunity for further study. And now I'll hand it back to our moderator.
Thank you very much. Next slide. So we just wanted to very briefly touch on synoptic operative reporting. So this is in the most recent publication of our COC accreditation manuals, there are 6 operative standards that were adopted as part of accreditation that has synoptic components. And so in order to meet compliance, COC centers are following these recommendations for the operative standards. And 4 of these have surgeons documenting critical elements of their operations in what we call a synoptic format. It's a bit of a change from the traditional narration style of reporting in which surgeons freely dictate procedural details. However, synoptic reporting has a lot of perceived benefits, including standardizing our language, standardizing the critical elements that show up in the operative reports, and they do so in a specific format so that everyone is really speaking the same language when we talk about cancer operations. The other thing to note here is that it doesn't necessarily replace the narration style, so that the surgeons are still dictating the things they normally do, but it does supplement the operative notes so that when any surgeon from any center sees an operative report from another surgeon, we know exactly what the critical steps of the operation were for the oncologic components, and we're all speaking the same language. So just as an example here, it's a synoptic report for sentinel lymph node biopsy, and in the left panel, you can see the critical elements listed, and in the right side, you see the synoptic responses. So for this one, it's very simple because most of them are yes, no, but therefore you're limited to a specific set of responses, and so it makes for very easy readability. And as well, in terms of data acquisition, it's easy to find these in operative notes for, say, an entire hospital system. So it's a really great transition, and something that most of the residents, I think, will be quite familiar with in the years to come. Next slide. So that kind of ends our lecture component of tonight's webinar. Thanking everyone for their attention. We're going to transition over to panelist perspectives. And so we're going to hear from each one of our panelists regarding their particular sort of insights from their experiences and their particular roles in surgery, and how the operative standards for cancer surgery can be applied for the benefit of education for trainees across our country. So I would like to start first with Dr. Hunt. So that'll be the next slide, please. I'll turn it over to you, Dr. Hunt.
All right, thank you very much. I think this is a great overview of the operative standards, and just to give you a little bit more history of how it started, when the American College of Surgeons Oncology group merged with a couple of the other NCI-funded cooperative groups to form the Alliance in Clinical Trials in Oncology, we began to look at some of the surgical trials that had been performed, and we realized that a lot of the documentation from the clinical trials, especially if it was a medical oncology trial, didn't always have the information about how the surgery was performed with respect to margins, lymph node basins, and other important components. So it was Heidi Nelson's brainchild to come up with these operative standards, and it was meant to be what happens in the operating room from the very beginning of the procedure to the end of the procedure. And it's not to replace your anatomy atlas. It's not to replace, some of the other things that you use to learn about the conduct of surgery, but it is very helpful in defining some very critical elements. So as you know from working with a lot of different surgeons, there's a lot of different ways to perform procedures, and some of these are great things to learn and great techniques, but they might not necessarily have an impact on the oncologic outcomes for the patient with respect to local recurrence and distant recurrence and survival. It's also important, as was mentioned, about the synoptic reporting. That was a really big component of what we initially developed, because we wanted to have a common language that people were using. Because if you read one person's op report, it's completely different from another and from another and from another. So, but if you look at now, the College of American Pathology does synoptic reporting for cancer, and if you look at how these reports are put together, it's very useful for many different clinicians to look at the synoptic report and be able to find the information they need. What was the tumor size, what were the margins, and so forth, and it's done in a synoptic format. And they can also provide additional narrative comments that may be useful to clinicians. So the idea of the synoptic report was so that a radiation oncologist, a medical oncologist, an imaging specialist, anyone can look at your operative note and find those critical elements that might be forgotten if you're just doing a narrative report. And so we know it improves quality. We've had some publications showing this, and breast cancer and gastric cancer and others, but we also know that it facilitates communication. And similar to the standards that we have for staging, we wanted to have operative standards that were communicated across disciplines and especially among surgeons. And so we thought that this would be an important addition to our standard oncologic care, and also help with clinical trial reporting and other things of that nature. So putting these operative standards together, when you look at all these different disease sites, we had hundreds of surgeons participating in the development of these manuals, as we call them. And I think that the other important thing that was brought up is the key questions, because there are areas of controversy that you'll hear about during your training. And we know that we can ask these questions in a clinical trial format and advance the field. So as you explore these operative standards, I hope that you'll consider some of your thoughts regarding potential clinical trials that we could do in the future to solve some of these unanswered questions in cancer surgery. Thank you.
Thanks so much, Dr. Hunt. Really appreciate your insights on that. That was great history. I'm going to turn it over next to Dr. Berman, and we're going to hear specifically about perspectives from a residency program director and a surgical educator.
So thank you, Dr. Lano and Dr. Hunt. So I think you'll hear a lot of repetition during the course of the night, because there's so many ways that everybody, no matter what stage you are, whether you're still training, early career, late career, an editor, an educator, use this, and it really is an amazing resource. So I think you'll hear a lot of repetition. I also was honored and lucky enough to work with the melanoma standard, both in volume 2 in the book and in the synoptic report. And first of all, as most cancer surgeons love doing, they love debating. So the key, the key questions kept us going for hours. If the ACS staff hadn't stopped the meeting, it probably would have still been going. But I must say I learned a lot, and it also changed the way that I dictated my operative reports even before synoptic reporting went into effect. So really is an amazing resource. And I chose to just go through a few quotes about this so people who are more eloquent than I am could actually put their input into this. So the first is from volume 1, the forward of volume 1, Dr. Hoyt, the prior executive director, who led the forward with the quote of, "This effort will become the standard by which cancer care is judged going forward and should be the standard for how all surgical care is taught." Again, since my focus is on the general surgery resident as a program director for 18 years, I think that this is a great quote and sums up things very well. Getting more specific, Dr. Kelly stating that in real world practice, cancer surgery is performed not only by general surgeons as well as specialty trained surgeons. So I think that this will feed into what Dr. Khan will talk about, how this resource not only spans the practicing surgeon, but those in training as general surgeons as well as specialty training as well. And then finally, a point that we already hit on by Tina Heiken, Dr. Heiken, is other anticipated benefits of the synoptic reports with their utility as a subtle, and I would argue it's not even subtle, it's obvious learning or teaching tool, and their potential to improve technical care more broadly. Next slide, please. So this is an incomplete list of how I think that this would help residents prepare. And the amazing thing is that this is available in SCORE thanks to the collaboration between the ACS and SCORE and the board. So the residents have this available to them. And prepare for OR cases. I mean, I see my residents scrambling to look at all these resources, and for cancer cases, this should really be the go-to one. And my volume 3 is still missing from my office. Volume 1 and 2 were missing for a while, but I finally found them. And I suspect it's the residents, although it could be the faculty who steal it as well. My residents, depending on where they're rotating, they'll write just a brief op note, which this is great for. But depending on if they're chief and where they're rotating, they may actually do the detailed op note. And what better resource is it to use this in order to give a pointed, hitting the key oncologic points? Sure, atlases may give you more of the positioning stuff, but this really hits the key oncologic points, as Dr. Hunt pointed out, and it's pointed out already. I quizzed my residents in didactics last week to ask them how many use this resource. And unfortunately, most of them said no, and it wasn't because they didn't think it was great, but because they weren't aware of it. And when I actually went through it with them, they were all like, wow, we should have been using this before. But interestingly enough, where some of my residents said they do use it is when they prepare for didactics, when they give cancer-related topics for grand rounds or for lectures, they use this to help prepare their lecture, which I think is great, and I didn't even think of that before. Certainly, the critical elements of the key questions are great for conference discussion, whether that's by the residents or by faculty bringing these up at M&M or other didactics. It's just, I think, an incredible resource. We already discussed about AppSite prep and board exam, and this is not only the qualifying exam, but also the certifying exam. Certainly, I think Dr. Khan could talk about that, but when you take your CGSO exam, those key questions, these will definitely come in helpful. And Dr. Hunt spoke also about the research. Certainly, for those who are looking for the key values that make up oncologic reporting, rather than having to read through all of this text, some of which could be enormously long, the synoptic reporting certainly helps with that. And Dr. Hunt also pointed out how the key questions hopefully will stimulate clinical trials to come. Finally, quality improvement. And I think this is both at the individual and institutional level, including, the synoptic reporting. Think of how simple that could make institutional, divisional quality improvement projects. So just Dr. Hunt went on this as well, so I won't spend time on it. But how is this a different resource? There are other resources out there. Well, I agree, it's not an atlas. This is data-driven focus on the critical oncologic steps, not necessarily on some of the, and I'm not putting down atlases, other steps are important, but this focuses on the oncology. And meticulous photographs and illustrations. I can tell you from the melanoma perspective, the diagram about what's the difference between a deep melanoma dissection versus a superficial dissection. We must have sent that diagram back at least 50 times. I'm sure people hated us and cursing us, but it was so meticulously done. And people actually said to us, you know, I never actually saw that the difference between those dissections actually spelled out and literally illustrated until it was published in this resource. It's not a textbook, it's not a review article. It is different and it stands on its own. And as I already mentioned, it's not a transcript of operative reports like you can buy out there, but it's really what you must know to prepare for a cancer case and what are the critical oncologic related technical aspects. So from my perspective, a general surgeon, any surgeon who does cancer operations, this is an invaluable resource that is available to them and could make such a difference in terms of their preparation for real work every day, real learning, as well as the exams. So I'll hand it over to Dr. Kang for the transition to fellowship training. Thank you, everyone.
Thank you, Dr. Rubin. I'd like to just reiterate a lot of the things for the Complex General Surgical Oncology Fellowship. A lot of the benefits for general surgery also are mirrored in the CGSO fellowship training program as well. So as we know from residencies and fellowships, you can have a different training experience in wherever you go. And so one of the benefits of these manuals is it provides a source for all different types of operations, even if you're not exposed to all of them. So perhaps you're in a program that doesn't see as much HIPEC or as much gastric surgery. And so these operations are all in these manuals. And you, as a CGSO trainee, you will be expected to know all of these. So it provides some consistency. The other thing is you're training with all different individuals for different levels and at different time points. So some of your attendings are going to be older and some are newer. And the nice thing is that this manual provides up-to-date evidence-based rationales for why you do certain procedures and what are the standards. So it's a really nice current resource for CGSO fellows. Of course, as Dr. Berman had noted, there's a qualifying and a certifying exam that all CGSO fellows have to go through. And so the SSO training committee actually helps administer the CGSO review course in January. And as one who has administered the breast questions, I can tell you that sometimes people are a little bit rusty. And so it's nice to have these books as an adjunct to that course before people are sitting those exams. It's really helpful for that preparation. And finally, as post-fellowship, when you go into the real world, if you're going to practice general surgical oncology and you're not, for example, an HPV specialist, or you're going to do upper GI, you're going to be someone who does a little bit of everything. These manuals are very helpful. And if you're going to an institution that's a COC accredited institution, you're going to have to follow the synoptic reporting. And these manuals really follow the synoptic reporting step by step, which is really, really helpful. In fact, ironically, as Dr. Hunt was talking about how this can help communication, just this morning, one of my surgical oncology colleagues was saying that a referring medical oncology colleague had questions about one of his operative reports, and he was able to actually reference the standards, which he found to be very helpful, and it helped the medical oncologist understand where he was coming from. So really at all different levels, from your time during training, post-training, through exams, and then as an attending, they can be extremely helpful. Dr. Villano, thank you.
All right, thanks, Dr. Kang. And then I do want to turn over to our resident perspective, so Drs. Rudisil and Horowitz, just for some insights from the trainee perspective.
So I think as a senior level resident in general surgery with plans to go into complex general surgical oncology, I'm on the interview trail right now. I think that these are directly translatable to what we're learning. And so I think it's applicable to all resident levels, whether you're a junior trying to prep for a case or whether you're a senior that's going to be taking on more reins during the case to get familiar with the critical elements and not just understand what you're going to be doing, but the why behind it and the evidence basis for all of that. And it's a discussion that you can have with your attendings in the OR as well. Also, on the flip side of things, going into board prep and absite prep and oral boards, I think it's really important to be able to be well informed on the key questions and be able to back up your answers with the evidence behind what all of this is coming from, that there's a reason that we have a certain threshold for lymph node harvest, and there's a reason why we go into certain planes. And so I think that that's been very helpful. Also in terms of absite and even going into research in the future, being able to find areas where you notice that there's a discrepancy in knowledge and saying, oh, this is a project that I might be able to delve into, and using that as something to come to your faculty members with. I think that they would receive that very well.
Yeah, I really agree with what everyone has said. As a trainee, it can be really challenging to find a concise resource that has consolidated but comprehensive information. And I think this really is it. Your time is finite. You need to be efficient and you need to be effective in your preparation for the OR and your preparation for ABSITE and board exams. I really like the standards, high quality CT images. I think Dr. Berman had referenced the amount of effort that goes into the anatomic diagrams of the nodal stations, which are excellent as you're a trainee poring over these over and over again to get them seared into your brain. And then for me personally, as a PGY3 resident about to enter into 2 research years, I really do appreciate how these key questions are highlighted. What are the gaps? In each chapter, it actually highlights the type of data, the strength of the data, and what those key questions are. And I think that can be very helpful as we try to move the fields forward to identify places where we can help move the field forward. So as everyone has said, this is a very efficient, effective resource for all of these things.
All right, well, thank you guys very much. Next slide, please. So we're going to go to our Q&A session momentarily. Just wanted to pause and thank everybody for sharing their personal insights into the operative standards for cancer surgery. I think everything was so well said, and you know, especially the residents, I know I really enjoy hearing your perspective, because you guys are, you know, you're the future. We're here to train you guys and educate you to carry on the next generation of surgery. And so hearing your excitement and, you know, your enthusiasm about using the resources and generating research questions, I think really sort of speaks to, you know, why the rest of us are here doing what we do. And so we thank you for coming on for this. So I'm going to go and kind of sort of individually dole out some questions, and although I may particularly pick out one of our panelists to initially answer the question, I do open to everybody else if you have particular thoughts about the topic that I raise. So I think for our first question, I wanted to start with Dr. Hunt. You know, I'm seeing one here. Are there any upcoming initiatives from the CSSP in regards to either more volumes for the operative standards for cancer surgery or other particular resources that may be kind of up and coming that residents will be able to utilize going forward? So do you have any inside info for us about initiatives that you might be privy to?
Yeah, thanks for that question. I'll say that the CSSP, the Cancer Surgery Standards Program, is the newest kid on the block with respect to the American College of Surgeons cancer programs. And Matt Katz is currently the chair, and Tina Heiken is the vice chair. And then there are several committees. So, you know, one of the efforts that we've been working on pretty heavily over the past couple of years is trying to get these standards, as someone mentioned earlier in the presentation, into the Commission on Cancer accreditation. And so that was a really heavy lift for all of the committee members, for the education committee, for the, you know, the other committees developing content and also standardizing the operative reports, which are also something that we have from beginning to end, all the synoptic reports, and that's a resource that you can look at on the ACS website. There's a toolkit that was put together by the Education Committee to have resources available for trainees and for practicing surgeons as well. I think that in terms of what's next, you know, we would like to back to some of the initial books like Volume 1 and updating some of the content there, because while much of it's still relevant, of course, the field continues to evolve. And so we have new standards, if you will, that may be appropriate for incorporating into the Commission on Cancer going forward. So there's a lot of different efforts going on in CSSP, and we also have involvement of residents and fellows in many of those efforts, doing surveys to find out what are the barriers to synoptic reporting and, you know, implementing the standards in your practice. Others have worked on tumor board videos to be able to display at your monthly or weekly tumor boards to describe the standards so that all the different disciplines understand what's going on. And then other efforts to collaborate, if you will, with some of the other cancer programs. As you know, there's the national accreditation for rectal cancer and also for breast cancer. So those groups are also developing guidelines and things that are important to cancer care, and we want to make sure that we collaborate with those groups across the cancer programs to facilitate the standards going into practice. So that's something, just a few of the things that CSSP is working on. Thank you.
Well, thanks, Dr. Hunt. I think very exciting times for the Cancer Surgery Standards Program, and education is expanding rapidly. So I'm always glad to have more resources for sure. Dr. Berman, this is an interesting question. For residents that are not going into a field like oncology, for instance, hepatobiliary surgical oncology, is there still a benefit to learning about the operative standards? And if so, where do you kind of see the biggest bang for the buck for the residents that may be applying for other surgical specialties but are still in a general surgery training program?
Yeah, that's a great question. Thank you. So first of all, you know, number one is before you can go out and do any sort of practice, you have to finish and successfully finish your general surgery training. That includes, of course, going for board certification, both qualifying and certifying exam. So, you know, I think that at least from my residents, they're always looking for cancer resources to prepare for their boards. And I think this is the perfect one. Sure, I mean, it could be detailed in some aspects of it, but I don't think you get penalized for knowing more than you should for your general surgery boards. So I think it's a great resource just for preparation for exams. Now, then there's practice. So, you know, when all of us, you know, I knew I was going to go into oncologic surgery pretty early on, but that also didn't mean that I didn't try to learn trauma and IBD, et cetera, incredibly well. You know, first of all, just because anybody who's interested in educating, whether it's residents, advanced practice providers, or whatever, you won't always necessarily be in a situation where you're going to be teaching only about your specialty. But also just to interact with your colleagues. And patients don't present with a single isolated focus of disease. Many of them have comorbidities that include other surgical diseases. So, you know, the more you know, obviously, the better physician and the better surgeon that you'll be in general. So, you know, I think what this does is this prepares you to be able to converse and understand the oncologic language as well as the steps of oncologic surgery. And that really crosses over so many aspects of care, both within the surgical world and the non-surgical world, that I don't see why this wouldn't be a go-to resource for any general surgery trainee, regardless of their interests. Hope that answered your question.
Oh, definitely, I think it does. This is sort of along, I guess, the same lines, this question. This is dedicated to you, Dr. Kong, but anyone else, please chime in. In terms of the fellowship level, and you touched on this a little bit, are there any particular aspects from the manuals that you think are probably the most critical at that level? You know, general surgery trainees and fellowship level trainees, I think, you know, as educators, we have different expectations as to sort of the level of detail and things that they need to know. Is there anything you feel like is sort of the most high yield that a fellow should, if they're reading the book, they should be peeling this particular information away for, and sort of banking that in their memory for, you know, not only their tests, but per se their practice when they get into their eventual first job?
I mean, I would say that the whole thing is high yield. I mean, they really condensed everything. You know, this isn't like a watery soup. This is like a bouillon cube. It's got everything in there, soup to nuts, from, you know, indications to, you know, I'm not sure where you would thin the fat on this. So I think it's all important. Kind of what Dr. Berman was saying, how, you know, general surgeons, you know, we have to remember that, and how does it apply to them? That, you know, there's a large population of patients that are cared for by general surgeons, especially in rural areas, right? So not everyone can go to, like, you know, Mass General and, you know, have a surgical oncologist do their, you know, their Whipple. I mean, you might be in North Dakota and you're going to a general surgeon. That's the closest you can go to. So these operative manuals are really good for general surgeons as well, who are practicing and doing some of these procedures, and they want to give high quality care, and this is helping them do that. And even if you're going to be in a larger metropolitan area, say you're a vascular surgeon, right, and you're going to be called upon to help your surgical oncology colleague, you have to understand what they're doing so that you can assist them in whatever they want you to harvest a vein for their Whipple or whatnot, you know. So I really think that it's not just for someone training in surgical oncology. I think it's really for everyone. I don't know if I hope that answers the question.
Oh, it does. It does. And I do appreciate your point about the sort of the concise nature of the chapters. You know, has been so long that I haven't been a trainee, and I can attest that the chapters are digestible in maybe 30 minutes to an hour, as one of the residents had said earlier. I think Dr. Rudizel pointed this out. You know, time is precious when you're a trainee, and you don't have many hours in each day, and so finding a resource where you can very concisely get the information you need and prepare yourself for the OR the next day is really important. So I do like that you both highlighted that. This one I'm going to kind of spread across all three of our trainees on the call, so I'm going to put you a little bit on the spot. But any advice for how, you know, residents can incorporate this into, say, their library of strategy for studying? You know, where do you guys kind of feel is the most potential benefits? You know, has it been for your studying for ABSITE? Has it been for your sort of initial preparation for boards? Do you feel like it's helped you doing research? All of the above? Kind of where do you think they should, if they're picking these books up for the first time, what should they be using it for, and how do they integrate it into their lifestyle? So maybe, so we don't all talk over each other. Dr. Rudizel, why don't you start with that, and then we'll go down the line.
Yeah, so right now as a PGY3, I find it to be best for case prep. I think, you know, anytime you walk into the OR, you want to understand the indications, you want to understand why those indications are in place and the strength of the data underlying that. And you want to know how to give someone a technically excellent operation. And I can attest to how thin they are. You can see right there, I have one right here. We keep it in our workroom, and, you know, when you are assigned cases, you spend the 20-30 minutes that it takes to review the chapter on the case that you're going to be doing. And I think that foundation is great, not only for the case prep, but it ultimately lays the foundation for taking the ABSITE, and I imagine for taking the boards later on. So that's where I see the most utility. I'm curious what my colleagues think.
All right, just so we don't talk over each other, Jack, I'm going to call out on you next. What do you think?
Yeah, so I can kind of speak on it from a different perspective. I learned about the Operative Standards manuals right at the same time when I was going out on 2 years of dedicated research. So admittedly, I didn't know about them in clinical practice, but having learned about them, having more time to do research, one of my mentors, Dr. Heiken, who was already referenced on the call, we did a retrospective review of January 1 to December 2023 of all the operative reports for standards 5.3 and 5.4. We looked at compliance, where there was issues, did some midterm interventions, kind of a quality improvement project, and then we submitted that to SSO that we're going to present down there. So a lot of opportunity for research projects. We have a bunch more ideas going forward after the first one. So for people on kind of the research side of things, there's definitely a lot of new frontiers and ways you can look at both quality improvement, which is what we did first, and then going forward, maybe look at more outcomes and with compliance to the operative standards and the SNOPS reporting.
Great, that's really cool to hear. Glad you're presenting that at the SSO. So we'll be there. I'm excited to hear about it. And then Dr. Horowitz, last but not least, what do you think?
I'd like to echo the sentiments that Dr. Rudisell said. I think it's best for case prep, and I think that it's a really excellent standalone resource. Again, it's not meant to replace a surgical atlas or anything like that, but I think it gives all of the details that you need to have kind of a more elevated understanding of the operation and what you're going into and the reasons why. And I think that in preparing for cases, it's certainly something that you can use alone and have a really, really good working understanding of the case.
That's very well said. And one thing that I think is going to be something coming down the pike from the education committee that, we have 1 or 2 videos up now, but hopefully we're going to have more, is we're trying to create this sort of library of, so sort of very brief 5 to 10 minute videos that you can reference or some of the more important technical aspects. There's one on the website already in regards to doing Whipple procedures, and so the SMA dissection portion. And so I think Dr. Timothy Vreeland was the primary author on that video, and I've watched it multiple times when I was a trainee, really kind of honing in on the SMA first sort of approach versus not. And those videos are really kind of high yield aspects, and so I think kind of another forward thinking aspect that hopefully as the education committee will get out to you guys is these sort of brief digestible videos from experts in the field where you kind of get a glimpse into what we're looking at in the OR and what we think is important, and so with some of the more technical aspects. And so that is something for the future, but hopefully we'll get there pretty soon. I think we have time for maybe one more question. I'm just going to check the chat box and see if we have anything else. I think I'll open this last one up to all 3 of our panelists as well. Where do the textbooks are really great resources. Again, I think we've highlighted all the different things that that they have for them when the residents pick them up. From the educator perspective, are there any ways you guys can think about a surgeon taking a resident or a fellow through a case? How can we sort of apply this to how we teach them? Are there any particular aspects of either the standards or the synoptic op reporting or the books themselves that we can kind of leverage as educators to suggest for our trainees to either maybe digest the night before or as they're preparing for our cases? Anything that we can utilize this for? I'll leave that kind of open for any of you guys to chime in.
I'll go ahead and start. I mean, I think that, as my residents become more senior and when they know they're going to assist me in the operation, especially if it's more complex, we obviously try to talk a little bit about it before the case begins, either the night before or the morning of, about planning and how we're going to approach it. And I think that one of the important things from the cancer surgery perspective is that it's not just how you approach things technically, but why you're going to approach it that way, how it fits into the oncologic principles. And what'll happen is my residents who really do the best, they'll ask me in advance, they'll be like, hey, I'm going to help you tomorrow. Is there a resource you could recommend? Because I'm using this particular atlas or, videos or whatever. And I'm like, well, yes, I mean, I get that and that makes some sense. But if you really want to know the why, and in addition to that, the illustrations or the pictures that really do show you to a large extent the how, I think that this is probably the best single resource that somebody could use. And that not only gets you through the technical aspect of it, but through the discussion that you should be having during the case about what the oncologic principles are and why you're approaching it that way. So that to me is the ideal use of this resource in that setting.
As someone, I'm a breast surgeon, so on our service we have PGY 1s and 2s, so more on the junior spectrum of trainees. And I think it's really helpful if they read before the case about what we're going to do. Many of times they haven't even seen some of the things we've done before, for example, an axillary dissection. And then we just use the step-by-steps in the manuals to go over and reinforce what they read about, and then show them in real life what these things look like. So even I think at the junior level, it's very helpful.
Yeah, and I can just add, I think, I mentioned earlier that when you're looking at the way the manuals are set up, it is pretty easy to digest the information in a relatively short period of time. And I remember as a trainee getting prepared for an operation, should I read this book chapter in this big book? Should I just study this atlas and get the anatomy? Well, of course you need all of that, but this does kind of condense it down into what are critical elements. And so if you're just starting out in a certain disease site, it does help you to pay attention to what are the most critical pieces. And then as you get more experience with that disease site, then of course you can go into more depth and study those things more, especially if it's something you want to pursue for research or for your future career. But I think there's just, it's like peeling back the layers of an onion. It's just like the more you peel, the more you find, and it's just still more and more interesting when you get into it. But I do like the fact that we started out with sort of books, standard books, right? But now we're trying to transition to more online materials that you don't have to buy the book, the whole book, or you can purchase the individual chapters. But as a trainee, like someone mentioned earlier, you're going to be coming across most of these things, but maybe not all of them. So it's kind of good to have that as a resource for all of the disease sites. And then as you focus your career in certain areas, then looking just for those individual chapters. But I do think that having the evidence base, and this has been mentioned by several people, understanding why you're doing what you're doing is really important. Thanks.
Can I just add one more thing? I mean, I don't have a bouillon or an onion analogy, but I could say that if one of your goals during the surgery is to favorably impress the attending as a trainee, there is nothing that a cancer surgeon loves more than to banter about oncologic principles, key questions, studies. So that's just an added bonus that you'll be able to have that conversation during the operation.
Yeah, I really like all of those points, and that was one thing I was going to mention myself is, when I first started reading these as a trainee, I really didn't appreciate sort of the why, and I think that really rounded out my knowledge base when I picked up these books is, the literature behind some of these things and how robust it really is. The residents picked the melanoma standard for the presentation for the webinar, and I thought it was such a nice sort of example, because there's very few things in surgery that we have such strong randomized controlled trial evidence for than wide local excision for melanoma, right? There's over 5 to 6 randomized trials, and we're in the midst of one right now. And so just having that sense of why is such a good way to solidify knowledge. I'll admit on, I guess nationally here that, as a learner, I was never really the best at memorizing minutia per se, but I think when I really understood reasons for why we did things or reasons why we used a particular technique, I think it really made it for me, cemented that I memorized it much better. And so that part of the books I was really surprised by, and it helped me focus, because sometimes I think at the fellowship level too, you don't really know what papers to read. There's so much literature out there. You get on PubMed, you can get 3,000 hits when you search for something. When you get into these books, you really find the highest quality evidence, the level 1 trials that inform what we do. And so for me, at sort of the fellowship level, that's one of the things I really got the most out of them. We're running a little bit short on time, but we do have time for one more question. It's kind of like a philosophical one, but I'll pose it to Dr. Hunt, since she has the sort of landscape of the field. What's the future for the operative standards going forward? Not even per se the books themselves, but what are the next steps? What are we all going to be looking forward to? Maybe not only just for the residents, but all of us in general.
Oh, that's a really deep question there. So let me see how I can try to address that. You know, in terms of the operative standards, I think what you have to understand in oncology is that the medical oncologists and radiation oncologists who are our partners in treating patients, they think that a mastectomy is a mastectomy, a pancreatectomy is a pancreatectomy, and you know, a lung cancer surgery is the same. And when the patient goes into the operating room and they come out, they're all going to have the exact same surgery. But of course, we all know that's not true. Patients are different. We really need to understand a lot more about patient, you know, the patient's genetic background. And as you know, immunotherapy is now emerged as a real game changer in some of these diseases that we thought were so difficult, like lung cancer and melanoma and some others. So I think being able to incorporate a lot of that new knowledge into our surgical treatment of patients is going to be really critical, because like as Amanda mentioned, she's a breast cancer surgeon, I do breast cancer surgery, and we're de-escalating a lot of the surgery that we used to do because of changes in systemic therapy and changes in radiation therapy. And so we need to understand what we're doing, you know, in the operating room, and help our colleagues to understand what we're doing. And when we talk about oncologic outcomes, a big important thing, of course, is quality of life. And so some of the things that we're de-escalating in breast cancer surgery is to reduce lymphedema that patients experience and improve their quality of life. And so as these things de-escalate, or as we escalate systemic therapy for certain diseases, we have to really keep our eye on the ball and keep track of the evidence, and you know, consistently update these operative standards so that they remain relevant and a great resource for all of us. Thank you.
Thanks, Dr. Hunt. So we do have one late breaking question, and with 4 minutes left, I do want to get to it. So I think you know, I'll throw this one out to Drs. Berman and Dr. Kong. So this question is, can you speak to how the operative standards interface and augment other clinical guidelines such as NCCN, ASCO, etc.? Sort of another semi-philosophical question, but what do you guys think?
Russ, do you want to go first? Go ahead.
Sure. I mean, I you know, yes, they complement, they don't replace. I think that, you know, when I view NCCN guidelines, I view an algorithm. When I view this, I view an educational resource and information that, you know, I could learn and take into a collective approach to a patient. So for a specific guideline, I view that as an individual patient type of approach. Yes, you can do the deeper dive into all the resources and the evidence, there's no question. But, you know, I usually use that at least for an individual patient approach. For this, you know, you can do the same in terms of the synoptic reporting, obviously, but I really look at the chapters and reread the chapters for more of a generalized knowledge as opposed to an algorithmic approach to an individual patient. Amanda?
So, you know, you can follow that. I'm going to take breast, for example. That's, you know, what I do. You can follow the algorithm. It's going to tell you to do an axillary lymph node dissection, NCCN. Great, you're going to do an axillary lymph node dissection. But it's not going to tell you, oh, you're going to look out for the thoracodorsal nerve. You know, it's not going to tell you if you injure that nerve, what are the side effects to the patient long term. So I think they complement each other. You can look at the Astro SSO guidelines, you know, for margins. Okay, no tumor on ink or 2 millimeters for DCIS. That's not going to tell you how to do the lumpectomy, right? So I think that you use it to complement each other, but not replace, as Dr. Berman's saying.
It also won't give you that beautiful diagram that shows the superficial versus deep inguinal node dissection.
Yeah, we'll say the illustrations in the text are they are quite nice. So we only have 1 minute left, so I want to go to the next slide and just have some closing remarks. So again, I just would like to thank everyone for attending tonight. Especially thankful to our panelists who devoted their time to join us for this exciting discussion. I hope that trainees and attending surgeons alike embrace the operative standards for cancer surgery and the robust educational resource they provide. Please be on the lookout for more educational material from the CSSP, and I would say in the near future. And with that, I would just like to wish everybody a really great night and really appreciate everyone's time. Thank you very much.